Good morning, everybody. A big thanks to Dr. Minu Mathan for calling me to deliver this talk on the ideal capsulotomy. My dear friends, as you are aware of, nothing is ideal in life. Similarly, nothing is ideal in capsulotomy either. Under various situations, various kinds of capsulotomies are required. They may be continuous, they may be rescued, they may be pinhole, there may be multiple tears. But the aim of a capsulotomy is to ensure that the nucleus is delivered safely. The ideal rhexis in a manual small incision cataract surgery would be that it is a continuous curvilinear capsulorhexis. But that happens only in perfect situations. Unlike in phaco, in SICS, a continuous curvilinear capsulorhexis is not mandatory. There are situations wherein the rhexis itself may cause problems. Like, for example, if there is a rigid myotic pupil, or there is gross pseudo-exfoliation, when there is subluxation, when there are black cataracts, where even a large rhexis may not ensure the smooth delivery of the nucleus. Therefore, I stand here as the devil's advocate to say that a continuous curvilinear capsulorhexis alone is not the ideal capsulorhexis. There are many other ways of doing a good capsulotomy. Now, this is a mature cataract with pseudo-exfoliations. This is a non-dilating rigid pupil. And then you have another condition in which it may be a non-dilating, non-rigid pupil. This one is a non-dilating rigid pupil. I can see the temptation in Dr. Suven's eyes. So here what we do is we go ahead with multiple sphincterotomies, either with a Vannis or with a microforceps. The pupil does not stretch to allow delivery of the nucleus into the AC. But when we do this multiple sphincterotomy, it can be done. Now the reason why this is being done is because there is pseudo-exfoliation and it is a non-dilating rigid pupil. Now this is one ancient technique which we used to follow in the late 90s. This is the envelope capsulotomy, in which we make two cuts on the side and connect them and convert the entire anterior capsule into a kind of an envelope, and then we deliver the nucleus out. It comes out comfortably, and then we implant the IOL. This is a non-dilating, non-rigid pupil, and this is an immature cataract. So we go ahead, inject visco, inject trypan blue, once again, as you can see, yes, this is an envelope, and then we complete the rhexis. And the Sinski is used to ease the nucleus out into the anterior chamber. Yes. And after this, it's a routine removal. Now this is a non-dilating pupil with pseudo-exfoliation, and this is an immature cataract. And we use iris hooks. We can use 4 hooks or 5 hooks, or use a Malugan ring or a Suven ring. The choice is ours. Normally in SICS, there is a budget constraint, and that is one reason why the Suven ring is not used. So if Dr. Suven can subsidize his rings for SICS surgeons, then there can be a mighty market for him. So anyways, the hooks are placed.
Are you aware? Also somewhere in India,
What?
a SICS surgeon charges up to 2 lakhs in one place in India.
Should be in Narayan Netralaya. Anyways.
It's just a joke.
It's a
It's
joke.
not true.
I know.
Charge SICS 2 lakhs. No, we don't do SICS.
Definitely.
Huh? No,
No, not you.
Not in
sir.
Narayan Netralaya.
I was making fun of our friend here.
I don't know, some
Narayan
place they might
Netralaya
charge,
doesn't.
but not in Narayan Netralaya.
No, this thing, not that. What I am saying is, somewhere in India, there is an SICS surgeon who charges 2 lakhs for SICS. So let's not go, we'll not go into that.
So that's not Narayan Netralaya.
Yeah,
I was
it's
just
not-
pulling
it's not
your
part
leg. Yeah. I think they charge that much for their gene therapy to inject lysyl oxidase into the cornea. Anyways, dear friends, the nucleus has been delivered and the IOL is placed. Now, this is a mid-dilated pupil, and here we do a rhexis behind the iris. Slightly tricky procedure, but this is something which we can do with practice. So the rhexis is initiated and it is taken behind the iris. This is actually not blind. This is the third eye of the surgeon visualizing the rhexis. So the rhexis is done. Yes. And we are checking the size of the rhexis by retracting the iris. And then, of course, the surgery is done and the IOL is placed in the bag. Now, this is a non-dilating pupil. There is severe pseudo-exfoliation and it is a dense brown cataract. In this situation, you can see the multiple side port incisions which were put, and the incision is made through the conjunctiva. Anyways, so we are going to use 5 iris hooks. To convert the pupil into a pentagon. In this case, we have an option. We can do a capsulorhexis or we can do a can opener capsulotomy. What would the audience prefer? Sir? It is always better to be safe than to be sorry. That is the correct answer. So we do the can opener capsulorhexis, capsulotomy, yeah. Deliver the nucleus out, and then we place a 3-piece IOL in the sulcus in this case. Please remember, when you do a can opener capsulotomy, please do not attempt to put the IOL in the bag. However beautiful and enticing the can opener capsulotomy may appear to you. Therefore, the take-home message is capsulorhexis is definitely an ideal choice, but not always the best choice in difficult situations. Always choose the method of capsulotomy correctly to avoid complications, and manual small incision cataract surgery allows a lot of freedom for us during the steps of the surgery, unlike phacoemulsification, which is comparatively limited in its many choices. I am not an advocate of SICS, but I only wish to understate the fact that the SICS is also a relevant surgery because it provides for a safe execution of cataract surgery and a safe implantation of an IOL and a safe insurance to good vision for the patient. Thank you very much, my dear friends.
Thank you very much, Dr. Sai, for insisting that safety we should consider before all these tendency to do only capsulorhexis and all those. So when we are faced with this kind of very difficult ones, very bad ones, be sure which is in your hands, which is your safest and for the patient, and please choose that technique.